Hey, welcome back, everybody. Time once again for that journey we call Living Hope. Your journey living with pancreatic cancer, sharing the real life stories of those really affected by this deadly disease and how they deal with it on a daily basis, including some hope. We've got some very technical discussion here today. I'm going to have to get out my medical dictionary to follow this one today here. Roberta, who'd you bring in?
Hi, Paul. No, I think she's going to do a good job explaining so that we can all understand. But today we are honored to welcome Dr. Lavanya Yohanathan, a highly respected surgeon who cares
We're
for...
laughing because you got close, but that's not really. How do you say your last name, doctor?
Yohanathan.
Yohanathan.
Thank you.
That was good though. That was good.
And we sit there and practice and it still doesn't work. You know?
We're laughing because
I think I'm just going to, from now on, allow the guests just to introduce themselves.
I
That way I
think
don't
that-
have to worry about
there you
it.
go.
Anyway, she's a highly respected surgeon who cares for patients with pancreatic, liver, and biliary cancers. Her focus is on complex treatment sequencing for advanced HPB cancers and transplant oncology. She also has been involved in some robotics, which we're going to learn about, but also, like I said, the transplant oncology really grabbed my attention. But before we get there, I would thank you for being here today and for putting up with my
And she's from.
mispronouncement.
We're having fascinating discussion. I just have to throw this out. She was born in Sri Lanka. Is that where you're originally from?
Yes.
And
Yep.
came here, and now you're in Michigan.
I'm in Michigan now.
There you go,
Quite
suburban Detroit, where I grew up. Go ahead.
Yeah, I don't know what it's like in Sri Lanka compared to Michigan, but
Probably very different, I would think. Probably not cold.
but we're very happy to have you here. So thank you, and thank you again once again. I apologize for messing up, but thanks for putting up with it. I do appreciate it. Before we get started, though, what inspired you to enter into the HPB surgery, and what drew you into caring for pancreatic cancer patients?
Well, thank you both for having me on this. It's really such a great opportunity to speak about this. And you did really good on my name, by the way.
Thank you.
So that's a great question. I think I get asked this all the time, whether it's through medical students or random people that I meet. I think going through medical school, I didn't really know that I wanted to be a surgeon, but when I did know, and it was mostly because surgery was just like super interesting to me, and it was nice to kind of have immediate results and help people and see the immediate aftermath of an operation impact people's lives and the family members that take care of these patients too. So that's what drew me to surgery, but it was almost a simultaneous decision for me when I decided I wanted to be a surgeon, that I wanted to do hepatobiliary or hepatopancreatobiliary surgery and focus on pancreas and liver cancers. And I think one of the main reasons is because it's one of the more complex operations that you do in the abdomen, but also every patient's different. And I think that's really interesting. I think it's interesting and really a privilege to be able to take care of patients who have such advanced disease, but able to provide them with options for cure. But also, even if cure is not an option and they're diagnosed with disease that's spread beyond the pancreas or the liver, then helping them kind of sequence the right way to take care of their problems.
And I got to
So I
pipe
think
in
it
for
offers like a unique opportunity.
one more clarification. You threw the real term out. We just abbreviated it HPB cancers because we
Yeah.
couldn't spell it nor say it. But say it. What and it defined what an HPB cancer is.
So HPB cancer is literally hepatopancreatobiliary, so it goes down the kind of anatomy of how it is in your body. So anything liver is the H part, pancreatic, P, and then B is biliary. So when it comes to liver cancers, it could be either primary liver cancer, so the most common being hepatocellular cancer and cholangiocarcinoma. And then pancreatic it could be pancreatic adenocarcinoma, which is the one that a lot of patients have kind of poorer outcomes with. And then there's neuroendocrine tumors, which have a more favorable prognosis. Patients usually live a long time with that problem. And then biliary cancers is, well, technically cholangiocarcinoma is a tumor of the bile duct, but depending on which part of the bile duct, it could be within the liver or in the bile duct outside of the liver. Most of these cancers are pretty complex. There are several physicians, surgeons, medical oncologists, radiation oncologists involved in the treatment of these patients. And depending on where exactly the tumor is and several other factors, those different subspecialties take a lead role in the management of these problems.
Yeah, thank you. Actually, that was going to be my next question, is to ask you that, because, like I said, I practiced to try to say that, and if I can't say normal things, I knew I wasn't going to be able to do that one at all. So we did. It's just easier to refer to it as HPV. So thank you. Um, so can you describe maybe what an HPV surgeon does for those that aren't familiar?
Hmm. Yeah, so most of the time, you will get involved in these patients either because they turn jaundiced or they have abdominal pain and they go to the emergency room or their primary care physician and they get a CAT scan and then they see a large mass in the liver or their bile ducts are dilated or there's a mass in the pancreas, or they become yellow, which is obviously a very alarming, not normal uh, thing to happen. And then from there, you work it up. So a lot of the times it requires a biopsy to kind of identify where exactly the cancer is coming from. And then depending on that, then there's different ways to treat it. I think we're in a very exciting time right now because not only is surgery an option, but there's different ways to treat different cancers, whether it's with chemotherapy, immunotherapy, the combination of different modalities of treatment. And I think that also is involved in like the treatment sequencing part because there was a time where it was only surgery or palliation. And now I feel like there's been so many advances with personalized medicine and next generation sequencing, which allows us to find targetable mutations to really increase the options for patients facing this problem.
I've talked to a few patients who thought they had something like liver cancer, but I guess when they did the biopsy, it was actually pancreatic. So there's a difference between, I mean, you can tell from the different cells, or how is it that you can tell that it is, maybe it's found in one area, but it's actually a different cancer?
Yeah, that's a great question. Really, the fundamental management of these cancers is either it's going to originate from the liver or it goes to the liver from somewhere else. So, for example, colon cancer, it primarily and can oftentimes go to the liver, and we kind of abbreviate it as colorectal liver metastases. And so several years ago, when patients had spread of colon cancer to the liver, there were no options for them. But now there are several options, whether it's taking out a portion of the liver. When patients get on chemotherapy, some of the lesions will shrink or go away. Now we have newer treatments. It's not very new, but it's definitely newer than it was like 10 years ago, which is hepatic artery infusion pump, where patients start with standard chemotherapy and then they could put a pump essentially into the artery feeding the liver and deliver chemotherapy directly into the liver. And there's been great response to that. There's like an active clinical trial in that space right now to study how that will benefit patients and how things work after that type of treatment and how many patients can get to surgery. So, but really, to kind of simply answer your question, a lot of times, if there's a spot in the liver, most of the time, there's a biopsy done. And then when the pathologists look at the biopsy and look at the cells, they can kind of tell where it's originating from, whether it's primarily from the liver cells or if it's come from somewhere else based on certain stainings and tests that they do.
And does that make a difference in the treatment where it originated?
Absolutely, yeah. So if pancreas cancer spreads outside of the area of the pancreas, which oftentimes will happen more likely than not, then surgery is not an option. And surgery is only the only curative option for these patients. So so when we have patients who have pancreas cancer, really only 25% of them are candidates for surgery because the rest of the patients usually have distant disease or metastatic disease, which is spread to the liver or lungs or lining of the abdomen, or they're locally advanced, meaning that they're wrapped around vessels in a way that getting the cancer out with negative margins is not possible.
And how do you determine whether someone is a candidate for surgery?
Right. So it's a great question. So first, you do a standard staging, which is you image them. You get a biopsy to prove that that's what's going on. You prove that it's localized. And then it really depends, especially with pancreas cancer, where it is in the pancreas, where it is in relationship to the major vessels. And the goal of surgery and the goal of every surgeon would be to remove or resect the tumor with negative margins. And that's what really equates to improved survival in this disease.
And how do you decide the best order or therapy, like, chemotherapy, radiation, surgery, to give the patients the best outcome?
These are all very great questions, like highly controversial, highly institution dependent. So, you'll meet several patients, or probably many patients that come onto this talk show that have the same cancer, similar cancer, but may have had different order of treatment. And this is something that I'm very passionate about because of the places that I've trained, where they kind of instill these principles into your kind of like algorithm of how you want to treat these patients. So in general, if there are tumors that, and I'm talking specifically about pancreas cancer, if there are cancers in the pancreas that are abutting or involving the vein and artery, then most of the time, those patients will start with chemotherapy. And that could be with the intent to get them to surgery, which we call neoadjuvant chemotherapy, or if the tumor is wrapped around the vessels where there's no way to reconstruct them in a meaningful way, then all they will ever get is chemotherapy plus or minus radiation. But the reason we start with chemotherapy in these patients is because we know that pancreas cancer has a tendency to spread. And we believe, a lot of us, that most of the time when patients present with this diagnosis, that some cells have already left that area. So we want to be able to identify the patients who are going to really benefit from a curative operation.
You mentioned that, like if the tumor, if it's wrapped around the vein and the arteries and whatnot, and that patient would probably have to be on chemo, I guess, for the rest of their life, for the duration. Is it going to be infusion, or is there an oral chemo that works?
It's usually infusion through a port, just because of how toxic the drugs can be. But, it really depends also on specific genetic testing as well, and specific markers as to what therapies they're available to the patient. And most of the time that would be kind of overseen by the medical oncologist based on their biopsy results.
I always hear, that pancreatic cancer is the most complex cancers to treat. From a surgical perspective, what makes it so challenging?
Great question. I think the biggest challenge, and also some of the greatest pride that we get in treating these patients, is because everything we do in surgery is all about location. You'll hear this all the time, like location, 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 and anatomy. And so the pancreas is kind of, I describe it to patients, it's like a little shrimp tucked behind the stomach, but it's in a location where if it's in the head of the pancreas, it's at a common intersection with the bile duct. That's why patients get jaundice, because it kinks off the bile duct. And then every other part of the pancreas is next to either a major vessel, either supplying the liver, supplying the bowel, called the superior mesenteric artery, the splenic artery, which is closer to the spleen side of things. So that's what makes it tricky, is that it can be wrapped around vessels, arteries, and veins that either you can resect and reconstruct or put them back together, or you can't. And so that's what makes it so challenging, is where it is in the body and how close it is to the major vessels supplying very important things.
You talked, or I learned, and this is something I didn't even have a clue and had never heard of, is the transplant oncology. What is that?
Yeah, that's a great question. So that actually, transplant oncology has been done for decades, but it's a term that was coined recently, and that's because it's basically doing liver transplantation for certain cancers. And that has been done for hepatocellular cancer, which is primary liver cancer, for many years. And so a lot of the cancers that we transplant or do liver transplant for, the data gets extrapolated from the experience from hepatocellular cancer. And other cancers that get transplanted are hilar cholangiocarcinoma, intrahepatic cholangiocarcinoma, and then now also for colorectal liver metastases and neuroendocrine tumors that go to the liver. So it is a unique set of patients who have a very strict protocol that they follow, with chemotherapy usually and radiation. For example, in hilar cholangiocarcinoma, it's called the Mayo protocol. And it's only for select patients. So either they have to be proven to have disease that cannot be resectable, or resected safely with negative margins, or in patients, for example, with hyalocholangiocarcinoma, if they have an underlying diagnosis called primary sclerosing cholangitis. And that's because their entire liver is diseased, and that's why they end up getting a lifetime risk of developing this cancer of the bile duct called hyalocholangiocarcinoma. And we know that those patients' survival with transplantation far exceeds anything you'd get with just liver resection. So it is a unique field where we identify patients who undergo treatment, and they have to go through a pretty rigorous protocol, and the protocol varies from one disease to the other depending on the specifics and nuances of that disease. But once they meet those metrics, then they end up getting some points or exception points where they then get put on a list and considered for liver transplantation for cure. So it's actually a very exciting field because it really gives options for patients who would otherwise be considered non-curative. And it's an evolving field. So there's more and more diagnoses where it's being considered. And even in the field of transplantation, there's so many changes, like the utilization of pumps for liver to test the liver and to utilize more livers. Because a lot of the times, one of the shortcomings is that there's just not enough livers for patients. So that's why all of the selection criteria for transplanting patients with cancer diagnosis is super strict, but it's definitely an option for select patients.
Oh, I think Paul has a question for you.
I have about 500 questions in here, but I know she was speaking English, but I couldn't understand half of the stuff there when you get into the scientific jargon. You keep saying negative margins. Our goals to cut this out with no negative margins. What does that mean?
That means getting the tumor out in its entirety. So if you
Nothing
leave some
left
cells
behind.
behind,
Right.
huh?
Nothing left
Leaving
behind the
nothing
mark.
behind.
Right.
Yeah, yeah. And so that's a combination of looking at a CAT scan to see where things are in relation to the vessels, planning the operation accordingly, and then also that specimen or the tumor specimen goes to pathology. They look at it under the microscope. So you want to always plan to make sure that you get complete clearance of the tumor, and that's what we mean by negative margins.
So we had
know
somebody
that
else on the show and we were talking about, so you're a surgeon,
Yeah.
you go in there. Do you just eyeball it? Is it obvious that's where it is and I cut it out? Or do you cut a little further to make sure you got it? Or is there some other indicator of where the cancer is?
Yeah, that's a great question. So a lot of the decision making happens before. So we can really heavily rely on CAT scans. They have to be done a certain way with the timing of the contrast and thin cuts. It gives you a lot of the information. It's kind of like how there's this huge emphasis on AI. So it's like the window to the inside, right? So you want to see it and visualize what you're going to do and where it is and what it's near. So you plan your operation that way. So if it's touching the vein, then you kind of already know that you're going to do a vein resection. So you get that information from a CAT scan.
And a vein resection
really,
is what? You pulling it back or you're cutting it out, the vein? That vein that it's touching,
yeah.
you're cutting it out. Okay.
You cut it out, yeah,
Right.
or part of it out, yeah. And then you sew it back together in a way where it like restores its normal function.
And if Roberta let me ask one more question that I have to ask. You mentioned what others have mentioned. You say it so casually, and yet it seems to be so critical to the evolution of care and the hope people have that they have these diseases, which is there used to be a search for the drug, the magic pill, the procedure, the thing that everybody got. You either got it or you didn't get it, but it was a pill, it was a drug, it was a cancer treatment. Now you're talking about personalized medicine where it's adapted to me. I get a targeted something. I get a special thing just for me. Is that the evolution of this disease and greater hope for living?
Yeah, it's like targeted to your tumor, right? They study the tumor. They look at mutational status. They look at whether or not there's something that could be targeted with a specific drug. And I think that's where there's a lot of advancements happening as we speak on how to best treat these cancers, because we know and we've known that these cancers don't behave well, right? They're historically ones with bad reputations. And so there's a lot of scientists out there that are studying how to target these specifically, and we're learning more about mutational status and how to appropriately treat patients with the kind of right combination of treatment. And I think that's important. And like you said, it's there's so many people like me that have trained in this subspecialty to kind of offer that type of nuanced approach, which has been out there for decades, and it's been done. But again, being able to do that for every patient, and having the resources in whatever institution you're at is important. And so I have been fortunate because of the places that I trained, to really be trained by people who pioneered some of these treatments, and surgeries and the way they look at the disease. So, as a surgeon, you want to be able to operate, and that's kind of why it's a very long road. But you also meet sometimes in your career people who train your mind how to think about these cancers. And so I think that's where the difference is. And I think that makes a huge difference.
Because it seems like surgeons get trained in a technique. Do it this way. Don't vary. This is how we always do this. And now you're saying, well, maybe we do it a little different every time we go in there, depending on what we
Yeah.
see in the patients themselves.
Yeah, you're right. I say to my residents, it's the same way each time. I set up the retractor the same way each time, and that's the way I was trained. But you do need to be able to pivot. And I think that's why it's such a rigorous training process, because you learn a lot of this, depending on the places you go and the people you see and the patients you see, right? Is that you sometimes have to be able to pivot, and you go in with a plan A, but always have a plan B.
And they don't do the transplant for the pancreas? That's not an
No.
option? Why is that? I mean, if you can do the liver and if you can't treat the pancreas, I mean, if it's you can't remove the tumor, why not do a transplant?
So pancreas transplant exists for other things like refractory diabetes and, hypoglycemic unawareness, or people who are unable to manage their diabetes. So they can get pancreatic transplants, and that's certainly done. Uh, but for cancer, you have to prove that there is a benefit of utilizing an organ. And the problem with pancreas cancer is that the tendency for it to spread is so high, that putting in an organ, may not kind of outdo that risk of distant disease or its potential to spread.
I know because pancreatic cancer has a really high reoccurrence rate, so that would, I assume, would be one of the reasons for not doing a transplant. But do we know why does it have such that high occurrence rate?
Yeah, I think the reason is because most of the time the symptoms don't show up until it's too late, right? So it doesn't cause symptoms. Like, so for breast cancer, you can notice a lump. For colon cancer, you may see blood in your stool. You may get blocked up. You can't eat or drink or have regular bowel movements. Those symptoms show up pretty early, even if the tumor is small. For pancreatic cancer, if you have pancreatic cancer in the tail of the pancreas, it's really not near anything that's going to bother you until it spreads. And that's why we kind of hear the really sad story that by the time I went in, I had a liver full of spots, or my lung had spots, and I couldn't get surgery. And it's because location of the tumor matters. And if it's in a location that doesn't cause symptoms, which is often the case, or it takes a long time to cause symptoms, those cells spread, and they go places outside of that area.
So I've known a lot of survivors who have been surviving a long time, 10 years plus, and then they get a reoccurrence. Is that because maybe it was laying just dormant somewhere and not doing anything, or is there some other reason for that?
Well, I think, with any cancer we deal with, right? Even the ones that have good survival. Once you have cancers, there's always a chance it can come back. So it spreads. Those little, it's called micrometastatic disease. They're in your bloodstream. But, completing a complete treatment sequencing of chemotherapy, radiation, surgery, one of those, all three of those, both of those, depending on what stage and what's recommended, prevents that risk of recurrence and development of disease or metastatic disease down the road, which is spread. But once you have it, there's always a chance it can come back. It's just with some cancers, it doesn't come back for a long time, and others, depending on certain features, it could come back sooner.
Are there any misconceptions or fears about pancreatic cancer surgery that you find yourself addressing with your patients or their families?
Yeah, I think that, unfortunately, Google is a very easily accessible resource. And a lot of the times, people who do really well with surgery, they don't necessarily go on there and talk about how great the recovery was. But it's just like human nature. So when something bad happens, then you will talk about it. I mean, I'm not going to lie or sugarcoat it. Some of the surgeries that we do are pretty involved, invasive, and definitely affect someone's quality of life. but it also affects their ability to be uh, what they're used to being. So I always tell patients that it will take at least 2 months for you to get back to your new baseline normal. And I think a lot of it is also how you frame it to people. If you say, yeah, you're going to have the surgery and everything's going to be great, that's what they're going to expect. I really do emphasize that your life won't be the same. There is a future risk of diabetes. You may need pancreatic enzymes. And I learned that from a lot of my mentors who gave truly the definition of informed consent, which is you got to really know what you're signing up for. And so whenever I meet someone with this problem, it's like a long-term relationship, right? You see them through all of this stuff and you see them afterwards. And so I think the biggest misconception is, will I die on the table? And certainly that risk is there, right? Depending on where it is and how close it is to some of the big vessels. But I do also think that there are so many great surgeons out there, so many people who have been trained in fellowships or have been doing this for a really long time that put a lot of thought into it. And so you want to always do your research on who you're seeing, what their center is like. And I think that's one of the biggest things is like you have to trust the person sitting across from you telling you about the surgery.
And will the robots help, or will the robots change everything here? We've had a number of people come on and talk about robotics. You said you've dabbled in it or done it or do it now or something here. Does it give you an extra tool to do what you can't otherwise do? Or is it seems frightening and yet it seems hopeful at the same time here?
Yeah, I would say I'm in my early phases of learning robotic surgery. I certainly didn't train in robotic surgery. It's definitely a newer thing. Some people have been doing it for years. It really depends on where you train and what you're exposed to. I definitely did more laparoscopic, and that was like kind of the cool trend a couple of years ago or a decade ago.
That's
I would
with
say
the camera or
maybe
whatever.
more.
Yeah.
Yeah, it's like the pinhole incision. Same concept of robot, but the robotics is actually like ergonomically better for the surgeon. You're sitting there and like operating on the console. I would say that honestly, the type of operation you do, whether it's open or robotic, you just want a surgeon who understands the disease and knows what they're doing and have done this and think about the disease as a whole. I think there is definitely advantages to doing robotic surgery, especially in patients whose BMI might be higher. But I would say that for some of the complex cases,
what's the DMI? What's that?
Body mass index.
Oh,
so
body
for
mass index.
Very obese patients, there's definitely a technical advantage of using the robot. It lets you kind of get into some planes easier, to let you see things easier than with an open incision. But I also think that when it comes to cancer, whatever is going to get you the negative margins, that's going to be the best way. And I think that there is definitely a role for robotics, as there was a role for laparoscopic, and there still is. But it really depends on every surgeon's experience and expertise with that tool.
Is there a higher survival rate with robotics, or is that something we don't know yet?
No, I would say no. I think it's going to be very hard. There have been clinical trials comparing robotic versus open, and it's never translated to improved survival.
Yeah, it's still hard for me to imagine, I guess, having a robot do my surgery, but
The surgeon's over on a video console here, moving little joysticks and stuff here.
But are they in the same room, or are they in a different? Can they be in a different room than the surgery's being done? How does that all work?
Where I am, you're in the same room. It's usually in the same room. You're close enough, because if something were to happen, you should be able to be close enough to undock and be able to do, complete whatever it is that you need to. And then there are a lot of very skilled robotic surgeons that can do the whole thing robotically. Even if they run into problems, they can fix it robotically. So I think, like I said, the expertise of your surgeon is going to really matter a lot. And then, as it comes to cancer care, whatever gets you your negative margins and the right cancer operation is the.
So what is the move towards robotics? Is it just a fancier scalpel? Is it more precise? Does it allow you to do things you couldn't do with your hands?
Smaller incisions, less pain, faster recovery, quicker return to normal activities, kind of the quoted superior aspects of robotics or minimally invasive surgery compared to open. Again, depending on the complexity of the operation, they may all factor out. It really depends.
And one more thing I see, we're at UCI's Beal Applied Innovation Center, a high-tech center where they're trying to take technology and turn it into something like most campuses want to do these days. Every campus has something like this. And here, the specialty is med tech and medicines. They've got lots of drug companies and drug labs and all sorts of techniques. And there's a company here that's focusing on using AI and pathology. The robot can analyze the better than a human to see things that the human might miss or overlook. That's their theory. Is there validity to that? Well, AI, because AI can take the whole database and really look for things that the human might, even a trained human might miss.
I think that these are all very exciting concepts, but it's taken decades, maybe centuries of work studying and learning about all of these things. So yes, if there's a perfect algorithm that makes AI capable of doing that better than a human, I say yes, we should absolutely use it. But I don't think that it's going to replace, a pathologist's ability to look at things and to be able to actually synthesize the whole clinical picture. And I think that the way I look at AI or newer technologies is that it could be an adjunct, but to replace something completely, that's a hard sell for me.
With all the advances that you're seeing, what gives you the most hope right now for patients facing pancreatic cancer?
I think, increasing awareness and knowing that there are options and knowing that there are ways to maybe think about something that may be borderline resectable or locally advanced, and then to be able to hopefully get someone to surgery. I think that is probably the most inspiring aspect of taking care of these patients, and it's a long road. But I think, again, with the right care team, that's possible, and that's kind of the type of patients that I oftentimes see. And it's a huge win when you can get these patients to curative intent surgery. And for those who don't get there, it doesn't mean that they don't have options. So I think one of the biggest things that we have seen change over time is that there's more awareness around how to still increase survival, even if it's not with surgery as like a piece of the puzzle. And so, there was a time where you heard the word pancreatic cancer and everyone was like, okay, we'll get everything in order. And some people do have really aggressive disease. But to increase awareness, which is why I think like this talk show is important, is because patients need to know their options and ask those questions.
What are some questions that you think patients should be asking the doctor that maybe they're not before they enter into any kind of treatment?
I think patients should always ask to be seen by all members of the team, whether they meet. So if they hear it from their primary care doctor, they should ask to be seen by a surgeon and a medical oncologist and a radiation oncologist. A lot of the times you'll work, if patients are at academic centers, that's tied into the system. But if you're at smaller centers, then sometimes you have to be your own advocate. And so you need to ask to see like a multidisciplinary team or a bunch of different experts who focus on pancreas cancer or liver cancer. So I think being your own best advocate is the best way to be.
And is that harder to do? I'll pipe in again. Roberta comes from a small town in New Mexico. She talks about all the time, there was nobody who knew about this. There was one doctor in town, and so how do you get that full range of options? How do you meet a whole team if there's no team around? If you're in these medical wastelands that are growing in the middle, outside of the big cities here.
Yeah, well, I think more and more people will trade at big institutions or academic institutions and go back to wherever they were raised or, smaller towns. So doing the research and finding people locally is definitely helpful if that exists. Now, sometimes it doesn't. And so then you have to do the best that you can or try to get to a major academic center. But also like trying to reach out to organizations like PanCan and to know like what clinical trials may exist or what institutions in and around the area have that, because you'd be surprised that there are a lot of, community type institutions or hybrid institutions. That's kind of one of the places that's where I work out of, which is hybrid. It's like got a residency program and trainees, but there's a huge private practice component. And so, but we do all the things here, and I have clinical trials open here, and we have an incredible medical oncologists and radiation oncologists. So really trying to find the best local area is helpful because, when you're already dealing with a diagnosis like pancreas cancer, sometimes it is easier to be close to home. Now, if there's no good options close to home, then I think that there really are no great options other than traveling to the closest academic
And
center.
what's the state like around the world? We've never talked about this. If I have pancreatic cancer in Sri Lanka or in any other country here, are they light years behind, or are they advanced, or I don't know what the state of treatment is around the world outside of the U.S. here.
I think most countries are kind of up to par on like what the national guidelines is. We definitely have multiple societies that focus on hepatobiliary. So we have something called the AHPBA, which is America's Hepatobiliary Association, Hepatopancreatobiliary Association, and that's our official meeting that we have every year. I am on the council as a junior member at large there, and basically we have representatives from all over the world that come there. And then there's an international HPV meeting, and then there's something called Society of Surgical Oncology. So there's many avenues with international presence. So I would say that like there's no real difference in standard of care, and most places do follow similar guidelines.
Well, it's been
Fascinating.
amazing.
Yeah, really. It's just, we could talk for a long time. We've gone way over. And
Yeah, I think
go
we
way
could continue. And again, I think I would love to have you come back maybe after the holidays, after the first of the year, because there's so much more. Just really easy to talk with, and I would really love people to hear so much more from you. So thank you so much for your time and joining us today. We really do appreciate it.
Thank you for having me, and I'd be happy to come back at any point to talk about more things that are.
And how do they
exciting.
reach you if they want to find you in Michigan here in your practice here?
Yeah, so I can leave my email. Is that like how do I do that?
Well, you can spit it out if people are watching it on TV. If there's some place you want them to find you on at a certain site or a certain center or a certain, you tell us.
Yeah,
How do you want
so
people to find you or connect with you or learn more about you?
Yeah, that'd be great. So my email is my first name, so LAVANYA period YOHANATHAN at Corewell Health. It's one word, COREWELLHEALTH.org. I'm also on X under Lavanya Yohanathan, and I do have an Instagram account, which I will be using
Instagram
more.
and X. That's how to find doctors today here.
Yeah, yeah.
TikTok is
But my
next
email
year.
is great. Yeah.
And we'll put that
I
in the
don't have
notes.
TikTok.
We'll put your email in the notes so people can get that as well. So thank you
Perfect.
again. I
Yeah.
do appreciate talking with you. So thank you.
Of course. Thank you for having me. It's nice to meet everyone.
As long as you speak my name, I shall live forever is dedicated to Gary Fong. In February, Gary shared his 8-year journey with us and left us with these final thoughts. It's not about whether the glass is half empty or half full. What truly matters is choosing optimism, holding on to hope, appreciating each new day, and finding joy in simply waking up are what carry us forward. Thank you.
Well, there you have it. Some amazing information, a whole bunch of ideas, new fields, new ideas, new people like our guest here exploring new frontiers in modern medicine, different ways to do it. All brought to you here as part of this journey we call Living Hope, your journey with pancreatic cancer. And of course, if you need help right away, as always, there's numbers, there's places to call. PanCan, certainly one of them that we talked about here today. You can go look them up. As we always say, it's the locally here, it's patient services is 877 the number 2 PanCan, 877-2-PAN for the Pancreatic Cancer Action Network. For the OC Talk Radio Network, I'm Paul Roberts, thanking you for joining us, hoping you'll come back again and share this with somebody as we continue this journey together.